Another important issue is what happens if we use neoadjuvant therapy in colon cancer patients with deficient mismatch repair. And a very interesting set of experiments were performed by using the combined patient data from two trials, Foxtrot and NICHE-2, that were respectively neoadjuvant or perioperative chemotherapy and neoadjuvant immunotherapy for mismatch repair deficient colon cancer patients. Without entering in the details of the study, was clearly possible to compare similar patient populations that received either only chemotherapy before surgery or around surgery, or, as we have seen before, 2 cycles of nivolumab, the first one with ipilimumab before surgery, respectively in the Foxtrot and in the NICHE-2 trial. Therefore, when they used a similarly selected patient population, the authors were able to compare data from 94 patients within a NICHE-2 trial and 185 patients from the Foxtrot trial. The bottom line of the study is that clearly neoadjuvant nivolumab and ipilimumab was superior to chemotherapy, that was 5-FU oxaliplatin-based chemotherapy, regardless of being before or after surgery, in terms of disease-free survival at 3 years. You see, basically at 3 years, no patient recurred in the NICHE-2 trial, whereas 20% of patients recurred in the Foxtrot trial. And also, if you compare this by stage, beside the prognostic role of stage for Foxtrot, the immunotherapy was equally effective in both clinically defined T3 or T4 patients. And in any case, in all parameters of activity of neoadjuvant therapy based on immunotherapy versus neoadjuvant or perioperative chemotherapy treatment, always NICHE-2 showed that immunotherapy was superior. For example, look at the tumor regression rate, and so a way to assess pathological response between chemo and immunotherapy that was obviously in favor of immunotherapy. So in conclusion, neoadjuvant nivolumab and ipilimumab were statistically better and clinically more significant than chemotherapy strategy for patients with locally advanced colon cancer receiving as a neoadjuvant treatment immunotherapy versus chemotherapy. And this data further support the study and the attempt to implement neoadjuvant immunotherapy also in colon cancer patients, not only in rectal cancer patients that have a deficient mismatch repair tumor. Another issue, going back on, are we able to select proficient mismatch repair patients that respond to immunotherapy and have a predictive value for this selection, came from the translational analysis of 2 first-line studies that were done in Italy by the GONO group coordinated by Professor Cremolini in Pisa, the Atezo tribe and the AVETRIC trial, in which, by using means of analysis supported by artificial intelligence and digital pathology imaging for the tumor microenvironment, the authors tried to define if it was possible to find an immunoscore that was predicting for activity and response. And actually, they developed an immuno-oncology unit scope platform in which whole slide images were analyzed and were defined for understanding which were the cells that were within the tumor microenvironment and how numeric difference and activation difference could account for potential response or not to immune checkpoint inhibitors. So they used the 2 studies, the randomized phase 2 Atezo tribe study, in which for Foxiri bevacizumab was compared to the same protocol containing also atezolizumab, or when another PD-L1 antibody, avelumab, was combined in a phase 2 single arm to folfoxyri cetuximab. Obviously, in the second study, only RAS-RAF wild-type patients were considered. They used this as training cohort, model application, and model validation. Without entering the details of the study, they were able to define a group of patients considered with a high score for this AI biomarker informed digital pathology of TME, finding a good predictive correlation both in the Atezo tribe and in the AVETIC trial with progression-free survival and overall survival. Therefore, the authors can conclude that although exploratory and needs further validation in prospective trials, maybe there is an artificial intelligence-derived biomarker score based on digital pathology that could define a subgroup of metastatic colorectal cancer patients with proficient mismatch repair or microsatellite stable tumors, in which adding PD-L1 inhibitor, such as either atezolizumab or avelumab, can increase activity and efficacy of chemotherapy. Another issue is, can we increase activity and efficacy in MSS patients in metastatic disease by combining not chemotherapy, but for example, multi-tyrosine kinase inhibitors and PD-1 or PD-L1 inhibitors? An interesting phase 1b study was presented by combining fruquintinib, that is a multi-tyrosine kinase anti-angiogenic drug that is on the market for metastatic chemorefractory disease, with one PD-L1 inhibitor. And interesting signals of activity within all the limitation of this phase 1b study had been reported in Berlin when tislelizumab was combined with fruquintinib. But a more robust evaluation of a combination of a multi-tyrosine kinase inhibitor that can block several TKI, tyrosine kinase receptors that are linked not only to angiogenesis, but also to activation of epithelial to mesenchymal transitions, such as TYRO3, AXL, MER, and MET, is combined with an immune checkpoint inhibitor. And the study is the so-called Stellar 303 randomized phase 3 study. This study was done based on a previous phase 1b study, the Stellar 1001, in which manageable toxicity and interesting antitumor activity was shown when such a multikinase inhibitor called zanzalintinib was associated with the PD-L1 inhibitor atezolizumab. So the Stellar study was a straightforward randomized phase 3 study in refractory patients who have been treated with all available chemotherapies and or biologic agents that were appropriate, and had an MSS or proficient MMR tumor. 901 patients were randomized to receive a standard regorafenib. The question can be, is still a standard regorafenib in this patient population, versus zanzalintinib plus atezolizumab. And the key issue of this study was the analysis of one of the two primary endpoints, that is overall survival. As you can see, overall survival is on the wall, improved with an hazard ratio of 0.80, median of 10.9 months versus 9.4 months with regorafenib alone, and therefore shows a statistically significant improvement in overall survival, although not yet of high clinical relevance, but maybe a signal is there where to find which are the patients that will most likely benefit by the combination of zanzalintinib and atezolizumab. And in any case, this is the first randomized phase 3 trial after a series of negative trials showing that in MSS tumors, by using an immunotherapy approach, in this case combined with a broad-range TKI inhibitor, is superior to a TKI in survival for patients with metastatic colorectal cancer that have failed all previous therapies. The co-primary endpoint of the study was analysis in patients without liver metastasis. There is a trend also in this patient population. You see survival goes from 12.7 months with regorafenib to 15.9 months with a combination of atezolizumab and zanzalintinib. There is still not yet a final answer on this co-primary endpoint because data are not mature yet. And if you look at all subgroup analysis, there is no clear difference in any obvious subgroup that we can consider for this patient population. And in terms of also the presence or the absence of mutations in RAS or liver metastasis or prior anti-VEGF antibody treatment, there is no major difference in terms of other ratio, although these are exploratory key subgroup analysis. Obviously, these are reflected in an improved progression-free survival. Regorafenib achieved the expected median PFS of 2 months that was almost doubled by the combination. And in any case, the problem is that this combination is rather cytostatic than cytotoxic. You know that in refractory patients after 2 or 3 lines of treatment, we still lack an active treatment that can improve the response rate. In terms of what this study has added to what we know for the treatment with immunotherapy or metastatic colorectal cancer with macrosatellite stable or proficient mismatch repair disease, we can say that this is the first randomized phase 3 trial showing an improved overall survival in a combination in which an immune checkpoint inhibitor, in this case the anti-PD-L1 antibody atezolizumab, was used. Which are the patients who will benefit best and how this will be translated to clinical practice, to my opinion, requires further knowledge, also because regorafenib was the comparator arm, and we know that for these patients, the comparator arm should be in modern treatment of metastatic refractory patients after failure of the first 2 lines, a combination of trifluridine and bevacizumab. Thank you for your attention.